Welcome friends, welcome back to the Medicine Unplugged series, which we carry on to enhance your knowledge through some kind of a clinical case presentation. For today we have got an interesting case from endocrine, that is a patient who is a case of acromegaly. Let's try to figure out the history that we have in the patient. Here is a patient who is a 45-year-old male who presented with daytime somnolence with some change in the voice and of course increase in the hand and the feet size. He also has developed diabetes and hypertension in the last 3 months. As well as the systemic examination done on the patient shows enlargement of the liver and the spleen size with enlarged hand and feet size. His growth hormone and IGF-1 levels happen to be elevated. Let me go back into the history again and again. He's a middle-aged male who has come with a daytime somnolence. Something that you must be aware of is a common occurrence if there is a deficiency of oxygen throughout the night or during the day, which can be a clinical case presentation of a patient with a sleep apnea. Voice change, yeah, and increased hand and feet size. Now, if there is an increase in hand and feet size, that means there is some soft tissue or a skeletal growth which has occurred in the person. And this is something new onset, diabetes and hypertension at his age. So we have a patient who has got two endocrine abnormalities, diabetes and not endocrine but clinical abnormalities, diabetes and hypertension, with some skeletal changes, a daytime somnolence and a voice change. In the systemic examination, we went and see that his soft tissue organs in the abdomen like the liver and spleen has also increased in size with hand and feet size rise. Apart from it, in the clinical background, the lab investigation shows us his growth hormone and IGF-1 levels happen to be elevated. So in short, it looks to be a person who has got elevated growth hormone and the IGF-1 levels, with a background history of some new onset skeletal change, endocrine disorder like diabetes, and a systemic hypertension also. Before we understand the process, why does acromegaly occur and what is the investigation and the final treatment, it will be better if we rebrush our knowledge about the physiology of growth hormone, how is it secreted and what day of the time it's been maximum, and how is it related to the insulin growth factor 1. I request Anupam ma'am to update us with the physiological aspects of growth hormone.
Okay, so I'm going to talk about the physiology of growth hormone. And as you can see in this first slide, the growth hormone levels decrease with age. There is a very high level of growth hormone in the early childhood, pubertal phase, and then there is a steady decline in the growth hormone with age. If you look at the pattern of growth hormone secretion, you find that the growth hormone peaks in the early hours of night. What causes increase in the growth hormone secretion is NREM sleep is associated with increase in growth hormone. REM sleep is associated with a decrease in growth hormone. The stimuli which affect growth hormone secretion are primarily hypoglycemia being a very potent stimulus for the release of growth hormone secretion, for release of growth hormone, exercise, fasting, starvation, any kind of stress, even psychological stress, such as emotions, would cause an increase in growth hormone secretion. Amino acids, arginine, leucine increase growth hormone secretion. A very important stimulus for growth hormone secretion is ghrelin. Ghrelin is secreted from the stomach. Increased levels during fasting. This also increases growth hormone secretion. The stimuli which decrease the secretion is REM sleep, high glucose level, cortisol, free fatty acid levels. The regulation of growth hormone secretion, the growth hormone is secreted primarily from the anterior pituitary. You have the somatotrophs. Somatotrophs are acidophilic cells. Somatotrophs are 50% of the total. These secrete growth hormone. Growth hormone is regulated by the growth hormone releasing hormone from the hypothalamus and somatostatin. But the primary hypothalamic hormone which regulates growth hormone secretion is GHRH and not somatostatin. GHRH increases the growth hormone secretion from the anterior pituitary. Somatostatin decreases the secretion. But the primary out of the two which is more important is GHRH. GHRH and somatostatin are secreted from the arcuate nucleus of the hypothalamus. If you look at the actions of growth hormone, there are some direct actions and some indirect actions. Now, what are the direct actions of growth hormone is, growth hormone will, number one, increase the blood sugar level. It will increase the free fatty acid level. It causes lipolysis. This is one of the catabolic actions of growth hormone. This increases protein synthesis. That is an anabolic action of growth hormone. Number 4, it causes retention of sodium, potassium, calcium, phosphorus. These are your direct actions of growth hormone. Now, what are indirect actions? Indirect actions are via IGF-1, insulin-like growth factor 1, which is also known as somatomedin C. Growth hormone acts on the liver. Liver secretes IGF-1. IGF-1 has actions which are actually, if you look at it, almost opposite to the direct actions of growth hormone. IGF decreases blood glucose level. It is insulin-like in action, so it decreases the blood glucose level. It causes lipogenesis rather than lipolysis. It also causes protein synthesis, and very importantly, chondrogenesis. It causes growth of the epiphyseal plate cartilage. Now, the source of IGF-1 is the liver. One important point here, when you look at the growth hormone and IGF-1, growth hormone and IGF-1 are both water-soluble hormones. They do not require proteins for transport. But IGF-1 is transported with the help of a protein. So out of the two, growth hormone and IGF-1, it is IGF-1 which has a longer half-life. So when you're trying to estimate growth hormone levels in a patient of, let's say, short stature, the between growth hormone and IGF-1, what is easier to assay, what is more reliable, will be IGF-1, simply because IGF-1 has a longer half-life as compared to growth hormone. Now, another important point here is growth hormone and IGF-1 have got absolutely contrasting actions. So what is ultimately the net effect of growth hormone secretion? Now, growth hormone, the effect of growth hormone will depend upon what are the stimuli for growth hormone secretion. Is the stimulus fasting, starvation, exercise, stress? Then it is the direct actions of growth hormone which become important. But IGF-1 actions will predominate in certain age groups. IGF-1 release is maximum in adolescence, childhood and adolescence, because IGF-1 is responsible for growth of the epiphyseal plate cartilage, for the increase in the length of the long bones. The IGF-1 secretion is not going to be the same throughout life. Maximum in adolescent age group, and then decreases with children, then adults, elderly, it is very less. IGF-1 is responsible for the growth spurt at puberty. When suddenly we all increased in height was primarily because of actions of IGF-1. Now, the action of growth hormone and IGF-1 on cartilage. Growth hormone and IGF-1 have a synergistic effect on epiphyseal plate cartilage. Growth hormone, it causes the conversion of the stem cells in epiphyseal plate cartilage to cells which respond to IGF-1. It increases the number of IGF-1 receptors on cartilage. IGF-1 will then act on these cells and cause the growth of the epiphyseal plate cartilage. So this is a synergistic effect of growth hormone and IGF-1 on cartilage. Growth hormone causes the stem cells to differentiate into cells which respond to IGF-1. Synergistic effect. But IGF-1 also has an independent action on cartilage. So that means if you have a known patient of growth hormone deficiency, you will be able to produce some amount of growth by only giving IGF-1. You need not give both growth hormone and IGF-1. IGF-1, like I said, has a synergistic effect with growth hormone and also an independent action.
Thank you, ma'am. Now let's look into the patient again, that we had a 45-year-old male who developed recent onset diabetes, hypertension with some skeletal changes, with some organ enlargement that was seen on the physical examination. In this patient, there are sets of investigation. First, I'll talk about the blood investigations, in which we have the growth hormone assay. Somewhere we have found that getting a growth hormone assay is slightly unreliable. As ma'am told, there are various physiological stimulations which happen to raise a growth hormone in day-to-day life. So physiological rise from a pathological rise is very difficult to differ. Then number 2 happens to be, as ma'am told, insulin-like growth factor 1 assay. That happens to be the best screening test, because IGF-1 will be often been elevated in any patient with acromegaly and gigantism. As far as growth hormone, it can be a physiological rise more often. Then third comes to be the confirmatory test, which is the growth hormone suppression test. Now what we give in this, we give an oral glucose, that is 75 gram, and then after some time we measure the growth hormone. As ma'am told, that fasting raises the growth hormone, so the glucose happens to be inversely proportional to the growth hormone. So if I give glucose to anyone, the growth hormone should be suppressed. But in this patient, because we find that patients with any disease like acromegaly happen to be growth in the pituitary, that happens to be the pituitary adenoma. I will talk to in detail later on about this. But a pituitary adenoma will never listen to this kind of physiological thing. So if I give glucose to you as a loading amount, I will see a suppression of growth hormone. But in a patient with acromegaly, which is occurred due to any kind of a pituitary or a somatotrophic adenoma, to be more exact, there is no suppression seen. So this happens to be more authentic or a confirmatory test for testing for acromegaly on a biochemical parameter. So we got approximately 3 tests: the growth hormone assay, which is not very reliable clinically; the IGF-1 assay, which happens to be the best screening test anytime; then growth hormone suppression test, as all authorities claim, it happens to be the confirmatory test for acromegaly. Then more important than this happens to be the imaging for the skeletal, the limb x-rays, as well as the MRI of the brain. As I told, the most common cause of acromegaly is always a pituitary adenoma. So we need to visualize the pituitary and see something wrong is there or not. Now let's move into the investigation part. So like Diksha from pathology and Sumesh sir from radiology to discuss about the further pathological and radiological diagnosis of acromegaly.
Thank you, Dr. Anupma and Dr. Achin, for a detailed discussion on acromegaly. Now, as far as radiology goes, it has 2 parts. One is to look for the pituitary tumor, for which we do a contrast enhanced MRI. And in a previous unplugged video of DAMS, which we loaded a few days back, I have already talked about how a dynamic contrast enhanced MRI is done for pituitary microadenomas. So that part is taken care of. But acromegaly has, unique X-ray findings as well, which I feel are very important to be discussed, both from a undergrad point of view as well as a resident point of view. We have to kind of understand how a X-ray of this patient would look like. Now, the first thing I want you to look at is this X-ray of the skull, and you can see the face along with it. And I want you to look at how the shape of the mandible is. Can you see this? A lower jaw is actually more elongated. It is leading to some amount of malocclusion, and it has a more obtuse angle to it. This is called as prognathism. This prognathism is very typical of acromegaly, and this is a very, very beautiful spotter that you might get as a resident in the exam or as an undergrad in the exam as well. Another thing that is of importance to look at is that growth hormone excess not only leads to overgrowth of bone, it also leads to overgrowth of soft tissues. So that soft tissue overgrowth is often seen as by measuring the heel pad. This is a classic X-ray where we have measured the soft tissue at the heel pad, and we are trying to look for a soft tissue hypertrophy, although there would be differentials of this as well. But usually we take a heel pad thickness of more than 23 millimeter for acromegaly in this X-ray. And another thing that would be of use to you here would be that the pituitary tumor, before the advent of MRI, we used to look at the skull and we used to look at the shape of the sella. And I am sure many of you can appreciate, look at this sella, this looks more rounded. What is this? This is what is called as ballooning of sella, which is a classic multiple choice question also, that in acromegaly you get ballooning of sella. And I want you to look at the frontal sinus. Are you able to see a hyperpneumatization of sinus leading to frontal bossing? So again, a very, very classic X-ray finding of acromegaly. You have frontal bossing. And let me show you another thing. Look at this tufting of the distal part of distal phalanx, terminal phalanx, giving rise to something which is called as spade-like phalanx. Another interesting finding that happens in acromegaly is even the cartilage hypertrophies. So what happens is, in the initial phase of the disease, you have widening of joint spaces, and then paradoxically it would lead to a premature osteoarthritis changes. So widening of joint spaces is also a feature of acromegaly, as is premature osteoarthritis changes, spade-like phalanges, ballooning of sella, frontal bossing, and hyperpneumatization of sinuses. You can see this in both in the AP and the lateral view. You can see the prognathism, you can see the frontal bossing, hyperpneumatized sinuses. These are all X-ray features of acromegaly. So I thought in this video it would be more value to bring, if I talk about the X-ray and the skeletal findings. MRI findings we've already discussed in a previous video on prolectinoma, which if you scroll through the playlist called as DAMS Medicine Unplugged in the YouTube channel, you can actually see that video and correlate the two things. It is our endeavor to try to give you an integrated picture of the disease. Now I'll invite Dr. Disha to talk about the pathological aspect of this disease.
Alright, so now let's talk about the pathology of somatotroph adenoma. It arises from PIT1 lineage cells. This is a transcription factor which is positive, and it helps us identify the origin of the cells. As we know, they are GH and IGF secreting. There's an equal preponderance, equal incidence, male and female. And macroscopically, the tumor will be soft and whitish to maybe a little reddish, not much hemorrhage necrosis. But microscopically, we'll see disruption of reticular network. Now, this is a very important point, because we all know that an adenoma of pituitary should always be distinguished from hyperplasia of pituitary. So it's intact in hyperplasia, but it's a little expanded, whereas in adenoma, it's disrupted. So just to clarify this point, I just want to show you 3 different photographs of reticulin stain. The first one is normal. You can see nice islands of the cell demarcated by the reticulin stain. Whereas here you can see they are continuous but expanded. Whereas in adenoma, they are disrupted. There's no proper enclosed pattern. So reticulin stain helps us differentiate between hyperplasia, normal, and adenoma. Now, as far as microscopy is concerned, there are 2 types of somatotroph adenomas depending on the color and the GH secretory activity. So, densely granular and sparsely granular pituitary adenomas. Now, what I want you to remember here is that GH secreting granules are more in densely granular. That's why it has eosinophilic cytoplasm. And the other one, sparsely granular, as the name suggests, has lesser. So it takes lesser stain and is a little different in appearance than the densely granular. Now, GH positivity is of course present in both, but because the granules are more in densely granular, the GH positivity is more. The alpha subunit of the hormone is present in densely granular, whereas it's negative in sparsely granular. And all of this translates on a clinical level to there's a better response to treatment in densely granular. It has a more benign course as compared to sparsely granular. Now, this photograph in front of you, everything's said and done on a very crude level. This is a very pink photograph. It's eosinophilic cytoplasm. You can see cells with a lot of densely granular eosinophilic cytoplasm. Whereas in the other photo, the inference you get is that it's lighter staining as compared to the previous one. And here I've marked some cells with arrows. If you can make out, there's some pink fibrous bodies, pink fibrous bodies which seem to be indenting the nuclei. This is keratin filaments, aggregates of keratin filaments. They form spherical bodies called fibrous bodies, which is very characteristic for a somatotroph adenoma. This is the cytokeratin stain, IHC. If you can make out, there's a lot of brown blobs all over. This is what we saw in the previous slide on histo that appears next to the nucleus and kind of indents the nucleus. Very classical for somatotroph adenoma. Now, as far as genetic causes go, GNAS mutations are positive in around 40 to 60% cases, and they are usually the densely granular subtypes. And men 1 in 4, SDH-related familiar paraganglioma, Carney's complex, and McCune-Albright tends to have, there is a slight genetic susceptibility with these conditions. Now, we'll go back to, now that we've diagnosed the condition, we'll go back and see how to treat it.
Thank you, Dr. Diksha and Sumesa, for enlightening us about the pathological aspect of a somatotrophic adenoma and how will we go and image a patient with acromegaly. Now let's move into the final part. What's the treatment for it? There are 2 kinds of treatment. One is surgical treatment, medical, and between the two comes the radiotherapy. As far as the surgical treatment concerned, as I emphasize again and again, the most common cause is a somatotrophic adenoma. So the best therapy should be to remove it. Remove it by doing a transsphenoidal resection. So this has been an age-old process and a basic thing. The treatment of choice, or maybe the initial treatment for acromegalic patient, is most of the time transsphenoidal resection. Now patients who are unfit for surgery, who got too bigger size tumor which cannot be resected, invading everywhere, we can go in for a radiotherapy. But radiotherapy is not for every patient. It has been reserved for people who are not very fit for a surgical procedure. But the problem is, the most abundant cells in the anterior pituitary happen to be the somatotroph cell. Now, even after a full resection, we might come across patients ectopically secrete, not ectopically, but secreting growth hormone from the pituitary which has been slightly left behind. So we can go in for a medical therapy or an adjuvant therapy. Now the basic concept is this, that somatostatin happens to be a molecule which is going to inhibit the somatotroph cells to produce the growth hormone. So we got two kinds of somatostatin analog which have been tried for the patient, octreotide and lanreotide. And then there is another drug that's a growth hormone antagonist that's known as a pegvisomant. But the medical and adjuvant therapy is never thought as an initial treatment even, or neither a treatment of choice. The best therapy anytime is the surgical resection of the pituitary gland, radiotherapy for people who have been unfit for surgery, and a blanket cover for adjuvant therapy may be given post-op in form of somatostatin and a growth hormone antagonist. So I'll just summarize the patient again. We had a 45-year-old male who has been recently diagnosed with diabetes and hypertension, with some daytime somnolence which is suggestive of some sleep apnea because of the soft tissue growth which might have occurred in the patient. The pharyngeal orifice during sleep might have been obstructed, and of course we have got skeletal changes in the patient. So there is no wait and watch policy as such in patients with acromegaly. The thing is that patients with acromegaly, when they're diagnosed, they have been clinically silent for nearly 10 years. And if you don't treat the patient well on time, the lifespan of the patient will be reduced by approximately 10 years. So a rule of 10 slightly follows here. So early to find and early to treat, that's the motto in these patients. Investigation we have already done, treatment, and what are the various radiological things in a nutshell. I hope you liked this session. More to come, as picture abhi baki hai. More to come, and please do follow us on our DABS Delhi page on Facebook and YouTube. And we'll be updating you about the recent topics which have been coming recently in the exam in a better clinical view. Thanks a lot.